Hepatopulmonary syndrome. This is also a consequence of portal hypertension. Okay, little vasodilators are leaking into circulation, and as they leak, it causes a VQ mismatch, right? So if we start over here, you have a VQ mismatch in their lungs. The lungs are getting vasodilated when they want to vasoconstrict, right? The areas of the lungs that have low O2, the lungs automatically vasoconstrict those parts because they don't want blood going there. They want the blood to go to the areas that have oxygen. So it vasodilates at the bases. And if you remember back to for respiratory, the bases had the least amount of oxygen. The most amount of oxygen was up at the apices because air rises, right? So it's difficult to get air all the way down to the bases of the lungs, right? So air, it's hard to get it all the way down there. And if we vasodilate all the vessels at the base of the lungs, that's going to put us at risk for hepatopulmonary syndrome, right? So these patients have a very, very unique symptom. It's called platypnea. Right, so platypnea is where they have a shortness of breath with head of bed elevated. So no longer is raising the head of bed always the right answer, right? It usually was always, oh, patient short of breath, raise the head of bed. This patient, you actually lower the head of the bed, and now the vasculature is going to kind of even out as they get, to the head there, right? So there's an arm, right? So they're going to be evened out at this point, and they're able to oxygenate better when they are supine compared to when they are upright. Okay, so platypnea is unique to hepatopulmonary syndrome, and that happens because of pulmonary shunting. Right, we are vasodilating. Why are we vasodilating? That's what those vasodilators came from. Where? From the GI tract. Right, so the GI tract was trying to help itself, and then it didn't work. It worsened itself. It worsened its portal hypertension. Right, all the vasodilators are worsening the hypotension, worsening the their portal hypertension, but then also some of the vasodilators leak on through. They leak on through the pulmonary circulation, and they cause a VQ mismatch, causing hepatopulmonary syndrome. Okay, and some of the vasodilators do leak into the circulation, and the circulation starts producing little vasoconstrictors, and those vasoconstrictors are, hopefully going to help the constrict and restore perfusion to our kidneys, restore perfusion to our systemic circulation, but they're also not going to be broken down. So unfortunately, they're not going to be broken. Those little vasopressors are not broken down, and we get pulmonary hypertension. It's the opposite problem, right? You don't have these concurrently. It's one or the other. Usually, these are just complications that happen from portal dysfunction, portal circulation dysfunction. So we have all these pulmonary pressors that are going to cause a chronic pulmonary hypertension. And it's the same treatment for this pulmonary hypertension that it is for other pulmonary hypertensions, like with low oxygen states, chronic low oxygen states. They're going to be on sildenafil, they're going to be on epoprostenol, they're going to be on agents to vasodilate their lungs so they get better oxygenation, better VQ matching. Right? So these guys, unfortunately, will develop right-sided heart failure. And right-sided heart failure, is that good? Well, it doesn't sound good at all, but right-sided heart failure is going to start to back up, right? So right-sided heart failure is going to back up where? Yeah, into the lungs. The lungs are already hypoxic, but the heart is going to back up the lungs. That's going to back up into the what? The liver, and cause liver congestion. And liver congestion leads to liver dysfunction. And if you already have a cirrhotic liver, that's not great, right? Remember I told you that cirrhosis can happen just from right-sided heart failure? Well, now you're in here. Cirrhosis caused the right-sided heart failure, so it's like almost doing itself twice, right? So that's called cirrhotic cardiomyopathy, right? So it can happen because of pulmonary hypertension, but it's also due to these vasodilators that got into circulation, and the vasodilators got into circulation. They cause widespread vasodilation, and the body says, "I know how to fix that. I'm going to release what? I release the SNS, right?" So I got catecholamines and I got SNS activity, plus the RAS is going to fire off, right? SNS and RAS fire off, and now just like with CHF, was that good? No, that caused ventricular remodeling, and we're going to see some echocardiographic changes on echo. We're going to see that they have a heart that has diastolic dysfunction, a heart that is hypertrophied and doesn't fill well, right? So, and that ends up leading to reduced ejection fraction heart failure. So it's HFpEF, heart failure with preserved ejection fraction. And how did they get it? It was from their liver, because their liver was cirrhotic. The liver then, wasn't producing albumin, caused, worse than portal hypertension. The portal hypertension then led to release of vasodilators. The vasodilators then leaked into circulation, and the circulation tried to fix itself with releasing a SNS and RAS response, and that then cause the ventricles to remodel. So cirrhotic cardiomyopathy can happen, but also there's cirrhotic heart failure. That happens because of just straight up heart failure itself, such as from pulmonary hypertension or just from heart failure itself, when the heart backs up into the lungs. Okay. The last thing is hepatic hydrothorax. So hepatic hydrothorax happens when we have the low albumin that's being produced, right, or not being produced, the low albumin state that's happening because our liver's synthetic function is deteriorating and it's not producing albumin. Yes, it causes ascites, but also the lungs, what's going to happen to the lungs? It's going to cause a fluid just leave the vasculature of the lungs, and it's going to start filling up the lungs with fluid, right? This fluid is not bacterial. It can become bacterial. That's one of the complications, is they can get infections, but usually it's sterile, right? But yes, it's sterile, but it also causes a lot of dyspnea. Dyspnea on exertion. It's going to cause dyspnea when the head of bed's definitely when it's laid flat, unlike our hepatopulmonary syndrome. So it's going to cause this fluid to build up, and what do you do for this fluid? You never put a chest tube, so no chest tube for this, because that chest tube will never come out. It's going to fill up and fill up and fill up and fill up and fill up no matter what, right? You have to, restore the albumin, you have to restore the liver before this will go away. We can do thoracentesis. You can do a thora to fix it, right? So thora, you can do, so therapeutic thora right there. You can do a diuretics, just like you would do with ascites, to try to get rid of the fluid as much as possible. And another option is TIPS. So what does TIPS do? It takes the blood from the blood circulating in the portal circulation and reroutes it to the systemic circulation, and that can help with these guys. Okay, so that's the idea with these hepatopulmonary syndromes. There's specifically hepatopulmonary syndrome, but there's also other results from all these portal hypertension consequences of the little vasodilators leaking in circulation that will then ultimately lead to these complications here. All right, so as we talked about congestion, right, the heart is failing and it's failing further. It's going to start causing a venous congestion of the lungs, right? So the heart is failing. It's going to start congesting these hepatic veins here, and it's going to start congesting, and the liver can fail over time, right? That's called a cardiac cirrhosis, right? From heart failure itself is leading to a cirrhosis to develop, okay? So that's going to disrupt normal function of our liver. All right, so here's our central vein or our hepatic vein right here, right? And all that fluid backed up, and it's going to back up in here. It's to disrupt the function of our liver, right? So that can lead to recuperation of the liver event, that it keeps dying and keeps not dying, and it causes scarring and cirrhosis over time, right? So here's another picture. It's all backing up into backing up, and backing up, right? So that's congestive cirrhosis, right? From a congestive heart failure or heart failure with reduced ejection fraction, right? So it's a blood flow that's backing up into the liver, and that causes the liver to deteriorate over time due to hepatic congestion. And then more commonly, though, that happens, why would the liver develop a shock state or develop a dysfunction acutely? Or definitely acutely, but when they have a cardiac arrest. We have a cardiac arrest as a lack of forward flow to the liver. We were just talking about a flow of blood just backing up into the liver, but what if there's lack of flow to the liver itself? There's a lack of arterial blood flow, right? So cardiac arrest will do that. Widespread hypoxia, right? Just like you have hypoxic ischemic encephalopathy from hypoxia to the brain, you can have hypoxia to the liver. And how do you know that happened? Well, AST 3 times the upper limit of normal is greater than ALT, or ALT is greater than this one. Well, we're not going to play around here. It's greater than 1,000. When you're ever greater than 1,000, it's not like a viral illness or Tylenol overdose or a statin misuse. It is almost always a damaged liver as a whole, right? So they have an hypoxic state, or they have a shock state, right? That's going to cause a lack of flow to the lungs, lack of flow to the liver. So from the periphery, our liver is arranged in these sinusoids, these little 1, 2, 3, 4, 5, 6. These what am I trying to say? Not hexagon, but hexagon. Pentagon is 5, right? So this arrangement here is designed purposefully so that we are develop, we give a little bit of blood flow to the liver, because the blood flow to the liver, it gets oxygen from the portal circulation and nutrients. It also gets oxygen and nutrients from the hepatic artery, and that will then feed into the central vein and then will return back to the heart, right? But when you have hypoxic hepatitis or a shock state, that's going to have a definite lack of flow from the hepatic artery. You're going to have a lot of watershed infarction of these cells here, right? So you're going to see you have this lack of flow internally, and that's going to classically damage a lot of cells, a lot of liver cells. So you're going to have the dramatic rise in the ALT, right? So hypoxia could be a significant reason, ischemia of our liver. Another reason would be, as we talk about systemic hypoxia as well, this was a shock state, lack of flow, okay? And then impaired oxygen extraction can happen in a septic shock. So yes, they have shock state, but you have sepsis. And in sepsis, it disrupts the mitochondria of all cells, including like the kidneys, of the brain. That's why you get confused. The heart, that's why your heart can have dysfunction and low cardiac output after a while with septic shock. So can your liver, right? So all these lack of flow, lack of absorption of nutrients can happen because of these disease states, whether it be congestion, hypoxemia, right? It has reduced perfusion, or you have a sepsis process. These are all disrupting flow to the liver, okay? So here's our portal vein right there, right? That's what delivered blood to our, from our circulation, and this is what came cirrhotic over time. And that's why all the blood backed up into our portal circulation. And remember, if you had an ascending event from the biliary tree, right, it's going to escalate and it's come up here, and it's going to cause a direct ascending cholangitis right into the bloodstream. So it's a direct conduit right up from the bile duct all the way to the central circulation. Okay, there's another way to view what we've been talking about before with gallbladder issues. All right, so coagulopathies from cirrhosis. Why does this happen? Well, the liver makes a lot of coag factors, right? All of them except for the von Willebrand factor, right, is the only one it does not make. Okay, so von Willebrand factor is not made by the liver. That's formed out in the endothelia of the vasculature. But other than that, everything's made by the liver, right? All these coag factors are made. And if I have a synthetic dysfunction because my liver is failing over time, then that's going to cause me to make less coag factors over time, right? So I want to recycle them. That's what vitamin K is for, right? Vitamin K is going to recycle all of these factors, right? They're going to, your liver made them, it's going to recycle them. Warfarin is going to inhibit that, right? And that's why the treatment for warfarin is vitamin K, so you can recycle the factors while warfarin wears off, right? But someone with liver disease, they usually have poor intake, right? Especially if they're an ETOH history. So vitamin K can help the patient with coagulopathy, right? We can give them vitamin Ks to give them whatever the liver does make. Let's recycle it, okay? So vitamin K can be useful. Also B12 and folate. These guys don't eat great. So B12 and folate is necessary for RBC production, but it's also for megakaryocyte production, right? A megakaryocyte is located in our bone marrow, and that's where that's what makes platelets, right? So that's usually it just sheds off its little tentacles, and that's what makes your platelets, right? And if you have lack of B12, right, decreased B12, you have decreased folate, right? So decreased folate, that's going to lead to a decrease in platelet production. So it's important to replace B12 and folate as well. Obviously, we should stop the ETOH. They could have a viral infection we have to fix, right? And ETOH and viruses suppress the bone marrow, and that's going to cause a low platelet situation as well. Okay, so the liver makes the coag factors. It also makes fibrinogen. Okay, so fibrinogen gets made as well, and your liver is going to start upregulating some and making a little bit of this one and more of that one, and it's going to be correcting itself as much as possible, and it's going to be making more fibrinogen, for instance, right? So these guys are actually prothrombotic, despite low platelets, despite a INR that might be 2.2, they are actually prothrombotic. They are at risk of actual clots forming. And as we kind of touched on, if you form a clot in your portal circulation, that's going to worsen your portal hypertension. Right? You form a clot in the hepatic vein, right? That's going to, over here, that's coming from the liver, that can also cause a portal hypertension as well. So these guys still need VT prophylaxis, right? So when should you not give VT prophylaxis then? So all the way back in like first semester nursing school, we always told you never check the INR, never check the APTT for prophylactic doses of medications, right? Or VT prophylaxis, because that's not the goal of those medications. The goal is, or the consequence of the medications is that they could cause bleeding, right? If your patient's bleeding, obviously we're not going to give VT prophylaxis. And if your patient has a hemoglobin that's less than 7, you're not going to give VT prophylaxis. The other thing is if their platelets are less than 50, you would not give VT prophylaxis as well. But if they're greater than 50, go for it, right? That's perfectly fine. And as we mentioned, fibrinogen can get deteriorated with time. Platelets can get low with time because cirrhotic patients, they are actually pro-inflammatory at all times. So they're always inflamed and cirrhotic and scarred. So when you remember back from sepsis, when you have inflammation, that's going to prompt a coag cascade, right? That's going to cause a consumptive thrombocytopenia. Also, it will consume coag factors, so that can also make you at risk for bleeding. So if you consume clotting factors, is there a lab test you could do? Yeah, you could do INR. The other more important one would be your fibrinogen level, right? So fibrinogen starts getting lower and lower and lower. That means you're consuming fibrinogen, which is the building block of what? Fibrin, right? That's your fibrin mesh that forms your clot. All right, so if you have low fibrinogen, you're at very, very high risk of bleeding. So fibrinogen and platelet count are much more important than measuring an INR, for instance, right? Because what happens is usually people say, what's the INR? It's 1.9. Oh, let's give some FFP. What happens when you give FFP? It can be a last resort, but before a procedure, FFP is just going to cause volume overload, right? It's 300 cc's of frozen clotting factors that you hope will work, right? And they're going to, they're going to go into circulation, and at 400 cc, or say a good portion of that is just going to deposit itself into the portal circulation and worsen any kind of bleed they might have, right? So it's not beneficial to give FFP for these patients, right? What is beneficial is restore the fibrinogen. So how do I restore fibrinogen? How do I increase someone's fibrinogen? Just take it to a corner, turn on a bright light, and say, increase it. How do you make it happen? It's another blood product, and that blood product is called cryo. So cryo is what's given for fibrinogen. If the platelet's low, what do you give? Platelets, right? So give platelets for platelets, give fibrinogen for fibrinogen. And fibrinogen is disguised as cryoprecipitate, right? It's precipitated out clotting factors, right? The clotting factors including fibrinogen, right? Precipitate is when you take out something out of a solution, right? So that's what you're giving. You're giving not giving a FFP, which is just the plasma. You're taking the stuff out of the plasma and you're putting it into a concentrated solution, and that solution is called cryoprecipitate. Okay, so yeah, at first they are procoagulant and they're high risk for clotting. Later stages, as they're really, really end stage liver disease, they can be high risk for bleeding. But really, at the baseline, we're going to be giving heparin and Lovenox or enoxaparin as our usual go-to agents, unless they have what? Unless they have a low platelet or low hemoglobin. Okay. Other things you can do if you have money, right, is to give eltrombopag, right, or avatrombopag. These are TPO agonists. And what is TPO? That is thrombopoietin. Thrombopoietin is what's made by the liver, right? TPO is what gets made by the liver, just like EPO is made by who? By the kidneys. Erythropoietin makes more RBCs in the marrow, and TPO makes more megakaryocytes divide from stem cells in the marrow. So therefore you get more platelets. But if we can't make TPO, you can't make platelets. So you get thrombocytopenic, right? And then the spleen gets very, very nervous, because what's the job of the spleen? It's a platelet hotel, yeah, that's what it becomes now, right? So the spleen's job is to contract, right, when you have a trauma, so that if you just inject a whole bunch of RBCs and platelets in storage, so that when it came time to it, like it's storing away for the apocalypse, right? And it has all of its supplies, it has all the canned goods and everything, right? And it's ready to go for whenever stuff goes down. But when platelets are falsely low, it's going to falsely hold on and sequester platelets, right? So, oh, platelets are low, shoot, I should hold some behind. And that's going to help actually worsen the situation, okay? Also, the spleen gets congested with cirrhosis and portal hypertension. So you get splenomegaly or splenomegaly because of A, it's holding on to platelets, and B, it is getting congested with from portal hypertension. Okay, so yes, it becomes a platelet hotel. All the platelets just shacking up in there, and they are not functional. They are functional. They're just on vacation, and they're not helpful. Okay, so we have the splenomegaly that will occur. But yes, we could give synthetic TPO, and it's literally like a year course is like $120,000, right, for eltrombopag. So it's not exactly everyone can afford that. All right. So yes, it decreases the need for transfusions, and that can help because transfusions themselves, as we talk about with hematology, have consequences. But that is an option. Okay. So cirrhosis itself is pro-inflammatory. So therefore, we're going to be using a lot of platelets and consuming a lot of coag factors, consuming fibrinogen. So we got to keep an eye on someone who's bleeding. We got to keep an eye on their INR. No, not really. It's going to be more an eye on the fibrinogen and more of an eye on their platelets. All right, hemoglobin as well, right? We transfuse PRBCs for hemoglobin, transfuse platelets for platelets, and transfuse fibrinogen, which is found in cryoprecipitate for low fibrinogens. Okay, so that's the idea with coagulopathies and why they develop, right? That's the reason they develop. And when they happen, if they're on anticoagulants, which they might be, we can reverse that with PCC, right? Prothrombin complex concentrate. But usually we're going to take a look, do a quick survey of what's going on. And if they're going to get any kind of procedure, right? PTINR and FFP is not what we do, right? We don't give unless they're going for like a very, very invasive procedure, we might give platelets ahead of time to make sure it's greater than 50,000 and make sure we transfuse, have good transfusion targets and fibrinogen targets, but we don't give FFP prior to like a paracentesis, for instance, or prior to an EGD. That's just going to worsen their portal hypertension, and portal hypertension is going to worsen the splenomegaly and worsen the thrombocytopenia. So it doesn't make sense, right? And we've known this for many, many years. It's not a new practice.